Hello everyone, I'm Seiichiro Hukuhara from Keio University, Tokyo, Japan.
Hello, I'm Motohiko Kato from Keio University. We are very happy to introduce a recent study entitled Management of Perforation Related to Endoscopic Submucosal Dissection for Superficial Duodenal Epithelial Tumors. First, why did you decide to conduct and what is the aim of the present study, Dr. Hukuhara?
Well, ESD is recently applied for superficial duodenal epithelial tumors. However, duodenal ESD is reported to be technically difficult and at high risk of perforation. Therefore, there is a controversy over the indication of duodenal ESD. It is important to elucidate the appropriate management of cases with perforation. Thus, here we conducted a study to analyze clinical causes of cases with perforation related to duodenal ESD.
Previous studies reported the risk of perforation is at least 10%, and this is an important issue to be solved. Please explain the design of our study.
This is a retrospective observational study in a university hospital. Clinical outcomes of 264 patients who underwent duodenal ESD from July 2010 to December 2018 were collected from medical records.
How many cases were included in this study?
During the period, perforation was observed in 36 patients out of 264 patients, including 4 patients with delayed perforation. It means the rate of intraoperative perforation was 12.1%, which was lower than previous studies.
This is a large study. Then what were the main outcomes of this study?
Yes, to our best knowledge, this is the largest cases with perforation related to duodenal perforation. In the present study, among the 32 patients with intraoperative perforation, we compared clinical outcomes between 13 patients in whom full mucosal defect, including the perforation site, was closed completely, and the others. As you can see, the fasting period and hospital stay were significantly shorter, and the maximum serum CRP level was significantly lower in patients with complete closure. In addition, these clinical outcomes were equivalent to those in patients without perforation.
These findings suggested that complete closure for mucosal defect is very important. But complete closure is not always possible, depending on the size and location of the lesion. How should we do for the high-risk patients?
Actually, it is difficult to close a mucosal defect completely. For example, when the lesion was located very close to the papilla. For such cases, we try to place endoscopic nasobiliary and pancreatic duct drainage (ENBPD) tube to avoid direct exposure of bile and pancreatic juice.
Do you place nasobiliary or nasopancreatic tube, not ERBD or ERPD?
Yes, we are thinking about that external drainage is important for the management of complications. ENBPD tube was inserted in 8 cases out of 16 without incomplete closure. After perforation, surprisingly, no additional interventions were required in such high-risk cases. On the other hand, one patient without ENBPD developed retroperitoneal abscess requiring CT-guided drainage.
How about delayed perforation?
We experienced 4 cases of delayed perforation. In one case, perforation itself was very small, only 2 mm in a diameter. But we couldn't close because the duodenal tissue was very fragile. An ENBPD tube was inserted in 2 patients, while one other patient without ENBPD tube insertion developed an extended abdominal abscess requiring pancreatoduodenectomy.
ENBPD insertion could be a salvage treatment, including delayed perforation. Finally, please summarize our results and suggest what the study brought for the future.
Duodenal perforation related to ESD could be managed conservatively by multidisciplinary treatment including ERCP technique. Improvement of management of complications would enable development of not only ESD but also other endoscopic treatments.
Thank you.